the Saudi live endoscopy, one of the best meetings in the Middle East and one of the closest to all our hearts. So I'm pleased today to be with my friend and my dear brother, Dr. Nawaf, and the whole team here in King Fahd Medical City. And we have a task to deal with small lateral spreading tumor in distal rectum and sigmoid. If we start just sometimes before we go online, so let's show what we did and what is the lesion and what is our strategy. We aspirate the water, and if we look here, we have a lateral spreading tumor, granular mixed type. Endoscopic picture, please. So we have a lateral spreading tumor, granular mixed type with some dominant nodules. And before we start, we try two positions. Actually, we work now while the patient on right lateral position. So if you look here, you can see the gravity to the left and the lesion to the right. So this is maybe a better position to go with. And we start our incision from retroflexion. If you look here, so this is the cecal incision. We start the incision with some trimming. We have access to the submucosa. We use here Olympus X1 gastroscope. As much as we can use gastroscope, we go for, because it gives better stability. And we use hybrid knife flex I type. And we have here a nice access to the submucosa. And we do a wide incision. We didn't do a shallow incision in the retroflexion. And we do the same in the forward here. If you look, we have also here, and we have here again a nice access to the submucosa. And either we work from retroflexion or work from forward, try to connect both sides, then open the two lateral margins. What do you think, Nawaf?
That's a great strategy. Another option, if you're going to open a bucket and going underneath the polyp, reaching the distal end of the polyp, at the end you will make your incision.
Sure.
This will make more trap for submucosa. It will not make an extravasation of your substance behind the distal incision. So this is another also good.
Yes, I think what is important is not doing a circumferential incision.
Exactly, yes.
Also,
Ahmed,
yes.
When a general gastroenterologist see a polyp, and you said the superficial lateral spreading, so what is, and he's not expert, so
Needle out.
when I say this case is for surgery, not for Ahmed,
اسمح لي أنا talk to him.
how do you know your limitation?
Yes, go on, Nawaf, please tell us.
So usually for the polyp assessment is very important. First of all, you have to decide where is the location of the polyp and then the size of the polyp. After that, you have to use the Paris classification. So in our case, this is an 2A plus 1S C-side lateral spreading tumor, and it's a granular with mixed nodularity. The risk of submucous invasion in these cases is reaching 5 up to 10%. If there is a dominant structure, it can reach up to 20%. So in this case, it's better to resect it as an en-bloc resection. As we know, the EMR, the risk of recurrence is high compared to the ESD, and even the en-bloc resection is very good, the ESD. I think the guideline, they're going to change it. Any polyp is more than a 2 centimeter, they have to go for ESD. They cannot implement it right now because there's no many endoscopists able to do an ESD, so they cannot force the people
Can
to
you
do
check the pump, please?
EMR. But I'm sure in the future they're going to change the guideline. Any polyp above 2 centimeters has to go for ESD to be in a block resection. What do you think, Dr.?
Yes, actually, I think for general gastroenterologists, it's important to know what not to do, even if we are not sure of what to do. So, to go for surgery, to go for ESD, we can debate, we can talk, but what should not do, to take a piecemeal resection for such lesion, because this lesion have a high risk to have a deep submucosal invasion. So it's important to resect en bloc, and for such size you can't resect with en bloc EMR, so we go for ESD. So it's important to know what not to do. What not to do here is to go for piecemeal resection. We have a problem in the bump. Can we fix? What?
So the length of the tumor, the spreading, I mean 10 centimeter or
No, no,
No.
it's a matter of depth. Size and location is not a limitation. Just avoid submucosal invasion. Usually keep these in mind. Only submucosal invasion is a limitation, not the size. You may have small lesion like 3 centimeter, which is invasive. You couldn't go for endoscopic resection, but you may have a 30 centimeter lesion and you go for endoscopic resection. Actually, we try to work underwater, but we have a problem in the pump here. We try to fix, and then we will move to
So,
work.
so the message for general GI, if you find a big polyp, just give a clear assessment for that.
No, it's not working.
And do not take the biopsy. Optical diagnosis is very important, because if you take a biopsy, you will make more
So please try to
fibrosis.
fix. I have a
If you
bleeding and I
want
need
to,
the water.
if you decide to remove it and you did not remove it fully, you will make a fibrosis that will be very difficult, even
it
for
will not
an
work.
ESD resection.
Needle in. So please give me the grasper and please try to fix this, even if fix the other one, the old one.
So here we are facing
The problem here, we have a bleeding and we don't have an irrigation pump working. We try to fix this. So I shift to grasper and just I will be close to the bleeding. I do a compression with the cap and wait until we have the irrigation pump so we can use to fix this. Okay, remove this.
Yes,
Yes.
yes, Dr. Ray.
Your strategy was, I am asking, was pocket treatment
Will we do this? Actually, no, it's like a tunnel because we open the distal end, then we work from proximal to distal.
Second point, because the working channel coming from the 7 o'clock for this scope, is it not preferable to bring the lesion to the left side and to avoid the perpendicular approach to the muscle?
So it depends as much as you're comfortable. If you think that you have like a free movement, you can have a good tip control. It's not a limitation, and you can change the patient position to have the position optimal for you to work with.
So Ahmed, Nawaf, all patients take dual antiplatelets, anticoagulant drugs. So when you
So?
do a procedure like EMR or ESD, do you stop what is your protocol?
Yeah, the same as any GI intervention. So using of antiplatelet or anticoagulation, it has to be managed very well before deciding for intervention.
Okay.
These it will make it more risk of bleeding.
No, it's stop again.
And we know the risk of bleeding with a ESD is less than
not
an
working
EMR.
either.
So if you're able to manage an EMR cases with antiplatelets or ESD, almost the same.
Open,
Yes.
close.
So you spend your time to control it using all your modalities as go CRISPR, and that almost is 99% of the cases you're gonna to able to control it. That's which considered as immediate bleeding. But for delayed bleeding, you can close your defect if you are patient you're high risk for bleeding. If he's not on a high risk of bleeding, the risk of bleeding again it's not that high. But you can use your modality. Control bleeding during ESD, it's very good. You see Dr. Madkour is using soft coagulation, it's 5 and co-grasper, so the bleeding it can be controlled, it's very easy.
Now, okay.
Yeah, you can use peristaltic after resection just to prevent it, the bleeding.
Yes,
but
now
during the intervention, I'm not sure it's have any value in that situation.
Close.
Do you use Biostat for control bleeding?
During the procedure, rarely we use this, but post procedure it may be good to avoid delayed bleeding.
Yes.
Open. Close. Open. Close.
Yes, we're using soft coagulation.
Yes, here we use
five.
soft coagulation.
But you can use also spray coagulation if
Usually soft, if you use a grasper, usually soft is more
Good.
safe and better. Now it's controlled, but I wait to fix this. Yes, I hope it's fixed. Give me the knife. You know, this one is not opened so well, so I will try to open this part, and this is the distal end, and will.
here is a retroflexion view.
Yes, we are in retroflexion. And you can see the water to the left side.
Exactly.
It's again, yes, a work stop, but we have to deal with these technical issues.
So if you face the case like yesterday, Dr. Fatih and Dr. Noor, as fibrosis or invasion, so do you resect or do you keep the lesion?
Needle out. Fibrosis you will resect, but if like yesterday,
Invasion.
when they suspect an invasion, I think it was a wise decision not to go for resection for lesion, which almost will be malignant and will need surgery after, and you may need like a full thickness resection, so it's not wise to do this. I think this is the bleeding point. Now we control, and this is our plan. Press here.
We are not hearing. Sort. No.
Yes, Amr.
Yes.
Yes, Amr, go on, please. Yes. I can't hear Nawaf. Can you hear Amr?
I'm not. I can't. Can you increase the voice, please? Volume.
You hear me now?
Yes. Yes.
Okay, good. Sometimes in the case of the bleeding, you expose the submucosa and both sides of the bleeding vessel to get good
Exactly. Yes. Yeah, we agree.
Yes.
You have to expand the
Yes,
submucosa to
sure.
identify.
I think we done. We just was having a problem with the pump irrigation, but supposed to be done now. And I think up here is a bleeding point. It's like backflow, and I think it's done. And again, this is the right plan to go with. So because of this technical problem, we will continue like a dissection without going more underwater until we fix this. You can see now we do like a 90-degree plane rotation. Now to right is the muscle, and to left is the lesion, and submucosa is here in the middle. And we continue dissection towards the other side.
So the question, Dr.
No
Madkour,
bump at all?
So the question, Dr. Madkour, there,
Yes.
for doing a submucosal dissection, some people they prefer to start at the base of submucosa, and some people they prefer at the base of mucosa. So
I think we have like a quality of dissection, so it's a good. We should dissect near the muscle, especially if we have a suspicious lesion,
good.
so we can have a nice safety margin, and the pathologist can tell us about how is assessment of the submucosa. So we should be close to the muscle. Now we move to forward, try to connect both sides. I think this is the bleeding point from the back. And again, we may coagulate here. Any hope to fix this issue with the pump, or to change it to another pump? Because I think we need to.
I think that's the end.
I think this is the plan,
Exactly.
and this is the other side. Just tell me if we can fix or not.
Do you like under saline?
Yes, not even if not under saline all the time, but sometimes you need, the water to clean the lens. You need the water to do this. We shouldn't do without having an irrigation pump. I don't know, what do you think, chairpersons? If we have a similar situation, should we stop until we have it working, or just to do what I'm doing?
So, Ahmed, Nawaf, when you are in a high volume center like that and you see cases like this, and everybody says, screening colonoscopy is screening colonoscopy, drop the A425. We need to do more efforts in Saudi and Egypt. We don't want to see cases like that. Whose fault is that? Mass screening is difficult. I tell you, in Kifa General Hospital in Jeddah, we cover 10 primary health care, 10 to 14 primary health care, and without the red flag sign, without alarm signs, fit testing for everybody who is above 45, and anybody with positive testing, especially we are concentrating about red flag signs, and we collect about, when we say we are in the north cluster in Jeddah, Jeddah is 2 clusters, we cover about 2.5 million. We have about 100 fit test positive every month. And we're supposed to cover all these cases, but we done another. We do our best.
Dr. Hamad, I'm not sure if you can see us, but I think we connect both sides from the center. I will just try to aspirate fluid, clean my scope, and see. If you look here, this is the connection between anal and cecal side. I will aspirate fluid and assess if we want to dilate more in the center, or it's done and we started to open the two sides. We open the gravity side first, then the anti-gravity side.
Okay.
So, Ahmed, what about age? What do you do for cancer? There is any program in Egypt?
Yes, we have a screening program for, yes, at 40.
What age?
40.
Problem,
Yes,
Dr.
that
Hamad,
quite
here.
In England, they are saying it is 55.
I think it's.
No, I think Amr is there.
45.
Amr is member of the national. board for CRC. Amr, it's 40, right? Or I'm not right? So, okay, so we open this right side, which was the anti-gravity side, because it was difficult to open the gravity side. Then we still have this part only connected to the side. So we change the patient position again. So we have the gravity to the right. So it's more easy to open the left side. And you can see this is all lesion actually disconnected. And this is the margins from the right side to here. And we have this part now to the left side. And after we change the patient position, it's anti-gravity side. So it's more easy to try to deal with.
So, Dr.
And we are lucky we just fixed this pump. I think it's working now. I'm very happy with this water.
Great.
And we will go for dissecting this.
So another clue for the area was not dissected. The area it will be unhealthy. The area was dissected it will be turned to the pale mucosa. If you
Yes.
go back, Doctor, you see that's not dissected, so the color is almost as normal compared to the dissected
Yes.
area.
And the gravity is to the left. So we supposed when we open this, it retracted and like a natural traction. We still can do traction, but here we depend on the gravity to do this.
Yes, they will gonna to shift to the other room.
Solid here.